Hello, everyone. Welcome to the What About Rural Health podcast. You are listening to the podcast that asks the question too many people forget. What about rural health? I am your host, Chinasa Imo. Together, we are uncovering the stories, the challenges, and innovations that are shaping healthcare in overlooked communities. Today, we will be discussing when health systems fail, how financing constraints impact care delivery and patient outcomes. So when we talk about healthcare failure, many people focus attention in discussing the observed symptoms, such as the misdiagnosis, the clinical error, delayed treatment, workforce burnout, patients' non-adherence, or the rising cost of healthcare. Rarely do we pause to ask, why are these things happening? Why do they keep happening? Even when many people protest, some people take legal actions, by suing the medical centers or the care provider or whatever. But why do we continue to have this happen? That is a question that, should boggle our mind a little bit. Also, how is health financing division shaping care? How is it making care possible or not? Who delivers this care? Is it the people making the decision or not? And who bear the risks when systems fail? Many of the challenges we see in healthcare today are not always by clinicians or the patients because they are difficult, or the clinicians because they didn't do much. They are a result of how health systems are designed, how care is financed, and how incentives are structured, and how policy decisions shape what providers are able to do in practice. So when systems are underfunded, fragmented, or driven by the wrong incentives, clinicians are forced to work within constraints that limit their everyday ability to deliver equitable care. And when systems fail the clinicians themselves, patients are the ones who often pay the price, either quietly or repeatedly, and most especially, very horrifying for those who live in underserved, resource communities. So this conversation today is going to be a part of our series, Rethinking Rural Health Financing, Investment Opportunities and Challenges. And because rural and underserved communities continue to face system failure, the most visible and consequential outcome is that they get limited services. And then we begin to ask the question, what now happens when this care is threatened? What happens when financial decisions prioritize efficiency over care or short-term saving over long-term outcomes? And this is where my guests come in today. But before I introduce my guests, let's take a quick break. All right, back to the episode. We are still listening to What About Rural Health with Chinasa Imo. Without much ado, let me introduce you to our guest. Joining me today in the studio is Dr. Peter Kowey. He's a world-renowned cardiologist and long-term observer of health system functions and all malfunctions from the inside. Dr. Kowey is a professor of medicine and a clinical pharmacology at Thomas Jefferson University. He's also the former chief of cardiovascular diseases at the National Health Institute and the William Wyckoff Smith Chair in Cardiovascular Research at the National Institute for Medical Research. He's an internationally renowned, recognized expert in heart rhythm disorder and has played a pivotal role in the development of innovative arrhythmia therapies that have shaped modern cardiac care. Over the course of his career, Dr. Kowey has authored more than 450 scientific publications, trained hundreds of cardiology fellows around the world, and served on key FDA advisory committees influencing health treatment, how they move from research to practice. Dr. Kowey is also a fellow of multiple professional societies, including the American Heart Association and the Heart Rhythm Society. He has received numerous awards, including the Edward S. Cooper and William Oslo Award. He completed his medical training at the University of Pennsylvania and advanced training at Harvard School of Public Health. Beyond his clinical academic work, Dr. Kowey is also a writer, a novelist, and an author of several influential books on cardiovascular care and clinical decision making, including Deadly Rhythm and Cardiac Arrhythmia, Pacing and the Sudden Death. I hope I get that correct, the second book correct. His latest book, Failure to Treat, How a Broken Health System Puts Both Patients and Practitioners at Risk, takes a step back to examine the healthcare system itself. And we are going to draw heavily on this book for this conversation today. I situate this episode within this series because Dr. Kowey names something we don't talk about enough: how health financing decision, policy design, and system incentives shape the reality of care delivery. So today's conversation builds on that perspective, examining how health system failures and financial constraints affect clinicians' ability to deliver care, and what that ultimately means for patients' outcome, especially in underserved resource settings. So I am grateful to have him here for this conversation. Dr. Kowey, welcome to What About Rural Health podcast.
Chanasa, I'm delighted to be with you. I have to tell you that your preamble was solidly on point. And I think what you said about the fact that we don't frequently dive deeply into these questions about finance and how financing and the currency of medicine impacts the care of patients. It has a profound impact, and I know we're going to talk about several of those aspects. But that was one of the very big reasons why I wrote the book in the first place, because I wanted the public, as well as my colleagues, to focus on this question of the relationship between financing and quality of care. You used a couple of interesting terms that I think are very important, like incentives, and uh, and the way that physicians are incentivized, the way that they're paid, happens to be one of the prime reasons why we do have so many problems in our healthcare system. But I'm sure we're going to get into a lot of these questions. But as I said, your preamble was solidly on point, and I think set the stage well for the conversation.
Thank you so much for that intro. I absolutely appreciate it. And I wanted to ask you, like, okay, before we dive in, like, you know, why did you choose to pursue medicine as a cardiologist? But then you start talking about incentive, and that also can linger into saying influence. So I'm still gonna throw the question to you and I expect you to answer. So what drives you to want to become a cardiologist? In terms of who or what? Is there a scenario, a case, or a person who help you navigate towards this career path?
Yeah, it's a great question. It could be a very, very long answer, but I'll try to keep it a reasonably length. But I was my parent neither of my parents got out of high school. They dropped out because they had to take care of their families and work. So I was the first person in our extended family to even graduate from high school and go to college. And so I really didn't know very much about what I was doing. One of the interesting things, and I talk about this in the book, is when I was a kid, our family doctor was a very important person. My parents really worshipped this guy because he took such very good care of them. He was a very a very gentle, kind person, and when we would go to the doctor's office, they always felt like they were able to ask questions and get their answers and get the kind of care that they needed in a reasonable period of time and for really not very much money at all. Um, it was just I was very taken with the guy. And I like science. And so it wasn't that big a jump for me to begin to say when I was a little kid, I wanted to be a doctor. I had having no idea what I was talking about, of course. And I did go to medical school, and I was a bit of an immature person when I went to medical school, but I managed to get myself through the process. And by the way, medical school, I don't think people who haven't gone to medical school don't understand what a meat grinder it can be. It's a very, very harsh existence for the time that you're there. Very challenging. It's very challenging to these are kids who have been used to being the top of their class and the brightest, and they go to medical school and all of a sudden they don't really know anything, and they have to start really from scratch, and they're intimidated and scared and they don't want to hurt anybody. It's a very challenging experience, but got through medical school, and I was very interested in the brain and neurobiology, but subsequently got seduced into going into cardiology because of a couple of people I met who were really outstanding cardiologists and role models for me. And one of the things I tell people is we don't really govern, we think that we govern our careers, but we really don't. A lot of it is just circumstance, right? I mean, it's happenstance, it's coincidence. I just happened to have a couple of people that I met during my training that were influential, and I ended up pursuing cardiovascular disease and arrhythmias as my training process. But so I got there I kind of meandered down the road to the process, through the process to the end. But I have to say that I'm very pleased that I did it. One of the reasons I wrote the book is that there are a larger number of my colleagues, Janasa, who, when they're asked if they would go to medical school again, say they wouldn't, or they discourage their children or young people from going to medical school because of the horrible experiences that they've had. That to me is just it's just awful. I mean, it's past awful. It's just terrible. And one of the reasons that I'd like this book to resonate is that hopefully we can get our profession back to a place where we are proud of it again, and we'll encourage people to come after us to take the same path, because it is a wonderful profession. Unfortunately, there are many issues.
Thank you so much for this response. And I think that um, I can echo what you said from other people, other medical professionals that I have spoken with who are frustrated by the system. And sometimes it's not like they question the choice to go into medicine, but the environment that they come to see themselves practicing medicine does not match the motivation that drove them to want to practice medicine. And I work in the development health sector, and I see many of these medical professionals moving from medical care to public health, as epidemiologists and data analysts and all whatnot, not really being in the theater of care, but now being in the decision-making space, or, in the health system intervention space, because they don't want to deal with all of the frustration that comes with care delivery. So thank you so much for that response. And to our listener, I will implore you to reflect on the health system you interact with, whether as a patient, as a provider, a policymaker, or caregiver. Where do you see the system making care easier? Where do you see it getting in the way within your community? Who is carrying this burden when financing division get in the way of adequate care delivery? And what would it look like if our health system are designed to actually support care and not complement it? So as you reflect on this, Dr. Kowey and I will dive into the actual conversation for why you are listening to us today. All right. So Dr. Kowey, one of the things that come true early in failure to treat is the idea that many healthcare failures are not about bad clinicians, but about health systems that makes care difficult. And permit me to recognize your long years that you have spent in healthcare system. So before we go into discussing this financing structure and the policies that drive them, I want to start with this. Placing you as a physician, not now as a professor or an author, but as a physician who have delivered care for a while. When did it become clear to you that the many failures we see in the healthcare are actually designed into the system rather than caused by individual care providers?
The problem, Chinasa, is that it's been a very insidious process. I think physicians weren't paying attention. So what happened was we were taking care of our patients in 30, and as you've said, I I have a lot of accomplishments because I'm pretty old. I've been around for a while. I've been in practice for 42 years. So I've seen medicine change dramatically over that period of time, but it was very, very subtle. It wasn't that one day we woke up and said, "Oh my goodness, we're practicing differently than we did before." It happened over a very long period of time, and it happened so gradually that many physicians who gave up a lot of their administrative responsibilities hardly even noticed the changes. But when we finally woke up and said we are no longer practicing medicine the way we want to practice it, it actually was too late. We had already ceded responsibility to private equity, to large health systems, to administrators, and it was very obvious at that point that it was going to be almost impossible to take it back and to rectify things. So. Um, I can't say that there was a pivotal point, but there is one thing though that I noticed that was a really big change, and I think it has had a major impact on the quality of care, and that is visit time.
Mm.
In the old days, I had at least 30 minutes for an established patient and at least an hour for a new patient. And over the course of time, that has been ratcheted back so that new patients now are 30 minutes, established patients are something like 15 minutes. Primary care physicians have every 10 minutes to see a patient, right? So they're seeing about 5 to 6 patients per hour. That and the reason for it is obvious. There's a revenue issue. We've got to see more patients and make more money, right? Um, that people have patients understand that when they walk into a room and their doctor flashes in, asks a few questions, writes a few things down, clicks at the computer, and then leaves, that is a very, very frustrating experience for the patient. And you know what? It's also frustrating for the doctor. I remember, rushing from exam room to exam room in between trying to do my record keeping. Uh, and God forbid I should get a call from a referring doctor asking me a question about a patient in the middle of my hours because I would never catch up.
Yeah.
Um, that is one of the really evil things that's happened in medicine is that we don't have enough time to spend with our patients in the office.
Hmm. As you talk, as you describe these things, I reflect on me being a patient because each and every one of us has experienced healthcare in some way, whether through primary care delivery or, at the big hospitals. And the story is not the same. My last guest that I had, we were talking about patient turnaround time, and she quoted WHO standard of care is like to see patients within 15 minutes. I'm like, so how do you clock all of that in 15 minutes, get to examine the patients and get to actually probe into the social determinants of why this patient is presenting before you? Because those things are extremely important. But when you don't give physicians, clinicians the time to explore the patient's history, you would really not get, everybody get haphazard care delivery and patients are not satisfied. But the drivers of the health system are just about making money. So thank you so much for this response. I know that I do have a follow-up question that I wanted to ask you. Um But I think you kind of like explained it to me in a way that um brings understanding. Like these things, we didn't just wake up one day and figure out the health system is collapsing. Like they took a whole lot of time and these things get normalized. But what I want to ask in follow up is, are there things that in this kind of routinization of the new system, are there things that clinicians themselves just got tired of fighting about and begin to normalize them to say, okay, that's okay, we can work around this instead of fighting the system to fix?
It was we have been deluged with regulations. Um, Let me give you an example. I don't see children. I don't see children anywhere. The youngest people I see in my practice is about 18. But in order to renew my license, I have to take courses in recognition of child abuse. It's a 4 hour course, and I have to take an exam after I take the course and prove that I actually listened to it. And I have to do that every 2 years. Every cycle of my license, I have to do that. That's just one example of the insanity that goes on in qualifying physicians to practice. We have all kinds of requirements for our for the Drug Enforcement Administration, the DEA license. We have to take an 8 hour course for that in drug abuse, even though I don't see patients. I don't administer any narcotics at all in my practice. So there are a myriad of things, recertification, for our board certifications, examinations periodically, a very large number of continuing medical education credits that we have to acquire in order to get relicensed. And within our staff structure, we have computer-based training that we have to do every year, even though it's the same course and it's the same questions. And you may say, well, each of these things doesn't sound like such a big deal, but when you add them up,
Mhm.
you're talking about several hours to days of doing things that the physician is completely convinced is irrelevant to their practice and doesn't do anybody any good, and let alone their patients. Um, so physicians have basically just said, okay, fine, and just don't fight it anymore. They don't discuss it. They don't talk about it. They just try to get through it. Physicians are very compliant people. We've been trained, to do things the right way and to just keep our mouths shut. And that's what they do. But kind of the silence of the lambs, if you will, being brought to the slaughterhouse.
Mhm.
Um, there are many, many ways that we can fix this. We can reduce a lot of these regulations. We can implement changes, but it's going to require thought and a lot of process, and it's going to require a lot of physician participation in regulatory decisions that we currently don't really participate in at all.
Mm. Thank you for that response. As you were talking, I know that beside this being um it sounds like a very stressful annual exercise that physician has to go through. But like what I'm thinking is, a physician is a human being that has to go through all of this certification. And I know every time I see my primary care doctor, I don't know about those who work in the in the big hospital, but every time I see especially in the morning, he seems exhausted. Sometimes I look at him and I ask him, I say, it seems like you are the one who needs to take a rest. Not and not me, because I came well slept, but you are advising me to take a rest. And I'm looking at your face. You seem like someone whose day started like 4 a.m. and you keep going up until now. And I'm just curious to understand, like, how then do physicians do their day-to-day work? Like, how do they make decisions on how much time to spend on patients versus navigating all of these systems um, that they go through? And when you add financing and administrative constraints to it. How I'm just like, it's boggling me. How do they navigate all of these things to deliver care? What does it look like?
Well, as you're implying to us, it's extraordinarily difficult, and that's what you've heard about this, and everybody's heard about physician burnout. The consequences of burdening physicians with several of these tasks that you just talked about is they burn out.
Yeah.
Um, One of the things that in my generation, unfortunately, we did not talk a whole lot about work-life balance. It was work, work, work.
Mhm.
Almost all the people I went to medical school with were workaholics. A number of them suffered the consequences of broken marriages, alienating their children, or not being around for things. Um, Over the course of time, I've seen an evolution. I think the young physicians that I see now are paying more attention to their family time. Unfortunately, it detracts. It's this tightrope you walk. It detracts from their ability to read and to keep up, and to function as high-powered physicians. Um, One of the problems in the book that I talk about is medical education,
Yeah.
how difficult it is. That doctor you were just talking about who's tired, in the morning and during his morning hours, when is he supposed to read his journals, or when is he supposed to do a podcast and learn about a new technique or a new drug? Um, Unfortunately, given all of the constraints, that's one of the things that doctors has put aside. So many of our physicians are not keeping up and are not giving cutting edge care because they just simply don't have the time. Um, we really need to do, again, a better job in the medical education process. One of the things I preach to our fellow trainees and our residents is time management. Time management is a really important skill that nobody talks about in medical school, but it is the successful people in medicine and in all professions, in your profession, are people who finally learn how to manage their time so that they do have time for the things that are important to them. Um, and then finally, I have a little bit of a bias here, but I've also encouraged my colleagues, my friends in medicine, to seek out creative outlets, to do something that is creative, that uses their right brain instead of their left brain all the time, right? Uh, Mine has been writing, as you said earlier, but I know of many of my colleagues who now do art, do pottery, music, something outside of medicine that helps them to keep their balance. That I really think is a very strong element and something that should be stressed in the medical education process for our young people.
Thank you for that response. And I agree with all that you're saying. Like medical professionals, they also do have family and these things get in the way. But I want to pivot a little bit to ask you the tension that we see a lot between the the financial decision making and clinical judgment. And it comes up a lot in your book as well, where a whole lot of decision, irrespective of the physician's ability to clinically examine a patient and say this is the best course of treatment versus, i.e., insurance company of the patients deciding a different route. Where do you see that this biggest disconnect between these payers and financial decision judgment and clinical judgment within the systems is disturbing the ability of clinicians to do what they are supposed to do? And at what point do like clinicians be like, well, we're just gonna go with the flow and do what the health insurance people say?
Yeah, there's two elements to this very important question, Shana. So one is, and we've hinted to this a couple of times, and I talk about it in the book, perverse incentives. So doctors make money, and hospitals make money from doctors when they do procedures. Um, giving medicines to people doesn't generate revenue. Standing at the bedside talking to patients doesn't generate revenue, but doing procedures does generate revenue. So, unfortunately, there is a pressure on physicians uh, to do procedures to generate revenue. And the book goes into several cases where people who could have easily been managed with medical treatment or didn't need any treatment at all underwent procedures. And the book obviously emphasizes some of the bad outcomes that happened because of that kind of an approach. The other side of the coin, and the one I think that you're getting at even more, is the outside pressure on physicians to limit care. And that comes from medical insurance companies predominantly, sometimes from hospitals and administrators, but mostly from medical insurance companies um, will who make decisions about what they think is the best care for patients based on the economics of the situation and not necessarily on what's best for the patient. So the one that gets all the press is denials of care uh, by pre-certification. So I say you need a stress test, and the insurance company says, no, we're not paying for the stress test because the patient doesn't need a stress test. Um, about 14% in the United States, across the board, about 14% of tests that doctors order are countermanded by pre-certification. So about 1 in 5 or 1 in 6 tests that I order, I know I'm going to get some grief about. And you also intimated, and I'm really enjoying this conversation because you obviously have a lot of insight. You also intimated that doctors have two ways of going about it, right? They could just lay down and take it, right? Or
Yeah.
they can fight it. Fighting it sounds like a really good idea, but it is really hard. And it's made intentionally difficult by the medical insurance companies. So you have to go through several layers to get to somebody who will ultimately make a decision, a physician that is. So you have to go through a clerk and then a nurse and then an administrator, and then maybe if you're really lucky and persistent, you might get to a physician. Doesn't mean the physician's going to be in the specialty that you care about. It could be a pediatrician talking to me about a cardiology case, but they get to make the decision about whether what I'm asking for is reasonable or unreasonable based on their set of rules within the company. That is clearly a problem. The reason why it's difficult to argue sometimes is because physicians have abused testing. Uh, Physicians do overorder tests. But why do they overorder tests? Obviously, some of it is to make money, but a lot of it is because they are covering their ass. Okay, so this is where we get into the malpractice situation where you don't want to get caught taking care of a patient and not ordering every test because if you didn't order all the tests and something bad happens to the patient, they're going to come and point a finger at you. Errors of omission and rather than errors of commission. So there's lots of reasons why these things churn and a lot of reasons why medical insurance companies may push back. But in the end, the people who get harmed are obviously the patients who don't get the care that they deserve.
Yeah, thank you for this question. And I want to go a different, like a radical route to look at patient's perspective. I have listened to a patient complain so much about a the way she felt she was treated in the hospital because the doctor refused to do certain procedure that she have found her friend who had similar situation as hers go through, and to her she felt the doctor or the care team were not qualified or didn't care much about her. And like it's a whole gamut of challenge that care providers have to go through. And I get the part about my practice. I mean, I'm just reading about the news of someone who lost their child and they are suing the anesthesiologist because they feel like they gave the is it anesthesia too early or too late. I don't know, but you are not in the theater and you're making this judgment. And I get it that you lost a child and this thing come on physicians and they have to protect themselves. But sometimes, like, patients also overreach. I just wanted to, and I like to look at things from different perspective and throw them all out for why we see the breakdown in the system that we see today.
Well, you're just to get your point about this person in the hospital who really wasn't believing that they were getting what they needed. One of the big problems is, and again, I keep referring back to the book, but one of the problems is that patients are not always cared for by physicians that they know or trust. So somebody's in the hospital, they're being cared for by a hospitalist or hospitalists, several, who don't know them, they don't know the doctor, and they may get an answer, and it may be a perfectly reasonable answer, but they don't trust the person giving it to them.
That's true.
When my patients came to me and said, I think I need to have this test because my friend had it and I think I need to get it too. We would just sit down in my office and we'd have a conversation and I would tell them why I agreed or I disagreed. But I rarely got any more pushback because they trusted me, because we had a relationship. They knew who I was, they knew what I did, and they knew what I told them was an honest answer. Um, what part of the problem that we're dealing with here is fragmentation of care. People are being cared for by so many different practitioners that it's difficult for them to know who to trust and who to believe when they're in a very critical situation. I'm sure your friend was in the hospital. That person was scared and sick and needed to be able to get straight answers from somebody that they trusted, and it doesn't sound like that's happened.
Yeah, that's usually where it starts from. So because when trust is eroded, all sorts of things, start to show up. So I agree with you. But one last question before we wrap up this particular segment is I just want to know, did any of these change how you practice medicine? Over this number of years, any of these things that you have observed within the system,
Yeah,
inform how you practice
I
medicine?
know, I know I must have been contaminated somehow, but I fought, people around me laugh at me because they think I'm something of a dinosaur because I have fought really hard not to change the way I take care of patients. And so, when everybody else had to see patients in 15 minutes, I went to the administration and said, look, I'm not doing that.
Mm.
Um, but I was senior enough and important enough that I got my way. I really feel like it's been swimming upstream. I really feel like I've had to fight really hard to preserve the way I take care of patients. Um, for, for example, um, I have always insisted that my patients come to my office with their questions written down and with their spouse with them. When we were going to, I mean, not for routine appointments, but if we were going to make a big decision about a procedure or something, an operation or whatever, I pushed very hard to have time with the patient and their family. Well, they took away our consultation room. They said we're going to use the consultation room as another exam room, and I had no place to talk to people, and I got really angry, and I made them give me back my conference room. Um, but I've been very privileged because of who I am, and not all doctors have that kind of clout and can get what they want. And that's why I think that as a group, we with our patients have to really unite to try to reinforce the idea that patient care is the most important issue.
Oh, thank you so much. I love this response that you give, and I see like the place of self-advocacy in the workplace, what that do to help a little bit with how, all of us situate ourselves within the work environment. So thank you very much for sharing that advocacy side of you with me. We are going to take another quick break. When we return, we will pivot to discussing health financing as a care delivery constraint. Do you have a rural health story that needs to be heard? Whether you are a health worker, patient, policymaker, or advocate, we want to hear from you. Share your story on our website at www.whataboutruralhealth.com/stories and help us amplify the realities behind the data. Someone from our team will contact you with details on how to get your story published on our newsletters, website, and other media platforms. Welcome back. You are still listening to What About Rural Health with Chinasa. So, Dr. Kowey, let's talk specifically about health financing. We often treat healthcare financing as a background issue when we talk about, I mean, we've established that in our conversation from, all the way up until now. Yet we keep seeing financial and administrative structural issues being a component part of care delivery that shape how healthcare decision is made. And in your book, you describe how financial pressures and system incentives influence what care is even possible to deliver. So can you walk us through how these financial constraints show up in the bedside?
Well, I think your concentration on this rural health thing is really is a great example of what you're talking about. That is how financial constraints impact the quality of patient care. It's happening everywhere, but it's really happening in the rural areas where we've seen a number of hospitals either close or significantly curtail their services. Um, Again, in the book, the story about a young couple who moves to a rural area and has a child that has a congenital heart lesion. They assume that they're close to a hospital emergency room. And so when the child gets sick, they call an ambulance, but they find that that hospital actually closed their emergency department because they didn't have the finances to keep it open. And the child has to be taken to another hospital several miles further. And by the time they get the child to a referral hospital, he dies.
Right.
Um, that's not an unusual story, unfortunately.
Mm.
Rural hospitals are under immense amount of pressure. What's happened is that these small hospitals that subsisted with a very, very narrow operating margin in the best of times has seen a shift in their payer mix. So their revenues have dropped. Um, God only knows what's going to happen with all the Medicaid cuts and the Medicare cuts that are coming with this big, beautiful bullshit bill. Um, I'm sorry,
I
I can't
know.
control myself sometimes. It's throwing gasoline on the fire for these small hospitals that have been operating basically in the red for a long period of time. When these hospitals begin to close or curtail their services, there's going to be a number of people in rural areas who are simply not going to be able to access any medical care. When the hospitals close, physicians leave the area as well, and so it's not there's not going to be anything that they're going to be able to do about that. So these to make it even worse, private equity companies have come in now and bought up many of these small hospitals with the intention of bankrupting them and taking their real estate and developing it for some other reason and making a lot of money. So there's all kinds of pressures on rural health. Um, Here's another one that really makes me very, very angry. People in rural areas have depended on telemedicine. Telemedicine has been a tremendous improvement for people in rural areas, but as you probably know, there are proposals in the, or there's actually provisions in the new bill that are going to significantly cut back on reimbursement for telemedicine. Um, one example, Shanasa, that made me laugh was when I was during the pandemic when we were doing a lot of telemedicine. I was I have a number of I have patients of all ages in my practice. I have a number of very old people in my practice, and the insurance companies told me that they were not going to pay for my telemedicine visits unless there was video. They said you have to have video. I don't know why I had to have video, but they said if you don't do video, we're not paying for it. These patients are not tech savvy. Most of them didn't have the capability of getting on a Zoom call, or they didn't understand at all how to even use a computer. They knew how to use a telephone, and I could talk to them on the phone and get some progress. But when I did it on the phone, I couldn't get paid for it because the insurance company decided not to. That's big problem in the rural areas where patients can't travel long distances to see doctors, obviously. So it's another pressure point for rural care.
Thank you so much for that response. And I know I have had a couple of guests come to my podcast and talk about the advancement of telehealth technology and the access they provide. And sincerely speaking, in the absence of no care at all, telehealth would be a preferred way of providing access to care to people who would ordinarily not receive any at all. But I I want to reserve that place where I say it seems like we push attention from delivering care in rural environments just because we can do it via phone. And to me, that is where I have personal concerns with that. Like, how about, and I want to connect this to your earlier point about doctors not now being motivated to go to medical school because they don't find the match between the passion they have for medicine and the practice itself in the way that is happening now. The ripple effect of that is that there's a shrinking medical professional population, right? And that leaves a lacuna. The burden is now becoming double for rural health,
Mhm.
where people like us are advocating for healthcare providers to go to rural environment and actually provide in-person care. And I now hear a lot of technology, AI, insurance company privileging as if rural health people do not deserve to actually have a medical doctor use a thermometer to, check their body and determine what the diagnosis or the prognosis is and the line of treatment instead of just being on Zoom like we are and asking the person, what do you think is your blood pressure today? Like,
Well, I couldn't agree with you. I couldn't agree with you more. Telemedicine, as we envisioned telemedicine, it was something that we could do in between in-person visits. It can never be a substitute for in-person care. It's a ridiculous notion for all the reasons that you just stated. So just to give you an example, we have a whole bunch of patients in our practice who have pacemakers, and um, most people who have pacemakers go into their doctor's offices and they get their pacemaker checked. What we were able to do with telemedicine is say, we're going to see you in the office just like we always did every 6 months, but every 3 months, we're going to do a telemedicine call just to check your pacemaker so you don't have to go anywhere and do it. You don't have to take an extra trip to come to the office and have your pacemaker checked. It was it was a way of making patients, giving them some comfort and help at the same time that they felt that they were very tethered to our practice. Telemedicine is not a substitute for medical care. Telemedicine is another tool. It's just like AI. AI is another tool. It certainly will help, but if it's not integrated into a careful care plan, and there isn't a human being supervising that care plan, then it will fail, and it won't do the things that we want it to do. Another example, Chinasa, is nurse practitioners. So
yeah,
I'm sure you've seen a number of nurse practitioners now going out into rural areas and seeing patients. I think it's terrific to have nurse practitioners or physician's assistants as long as they're properly supervised. I don't, I know that not everybody agrees with this, but I think that physician extenders, people, associated professionals need to be supervised carefully by physicians. But when they are, it's just another way of us reaching out to our patients and providing care. And those people can be wonderful, and they are wonderful. We have several of them in our practice, but um, it all comes down to this central thing of a caregiver that the patient can identify as being their primary
yeah,
caregiver,
yeah,
and everything else sort of evolves from that.
yeah. Thank you. And I want to so when I read your prologue and you expressly um expressed concern about the over scientification of data and its use in healthcare decision making. And this is me still asking question around practitioners' expertise to diagnose and treat, and the way that data is now being privileged in the to somehow in some way, like, and I've seen this a lot in the hospital. It irks me, and I am a data driven, evidence based advocate. And just like we talk about integration of all of these tools, they are supposed to help care, improve care delivery, and not be the singular decision making. And I'm beginning to see that a lot where you are talking. In fact, I challenged one of my doctors who was telling me 80% of people for the procedure I wanted to go in for. I said 80% of people would choose to do this procedure and they would come out without. I told him I'm not statistics. I'm talking to you here like I took a shower and I came to you to have a consultation. Look at me in the face, because those 80% of people do not have either the commodified issues that I have, or their genetic, combinations have nothing to do with me. So me and them and that statistics are not the same. This is me speaking as a Nigerian, right? So would you share some of your example of moments where you feel that clinicians know what the right care is, but they are unable to deliver it because they have to use this data as sometimes imposed upon them by going back to insurance and administrators um, to use in making decision?
Yeah. Your point is so well taken because um, we we don't want to produce automatons, okay? We don't want to produce people who practice medicine with a cookbook, okay? Or algorithms. I hate algorithms. I hate them because they force everybody into a particular treatment plan. And what you just said a minute ago about I'm an individual. I deserve to have the care that's best for me as an individual. So medicine is a wonderful profession, and one of the most spectacular things about medicine is learning how to take information, data from the literature or from studies or wherever we can get it, and taking that information and integrating it into the care of individual patients. It's a real challenge. Um, it's something that it takes years to learn how to do properly. That's why we call it the practice of medicine, because we don't we have to learn how to do this. But when it's done properly, everybody benefits. So you bring the data from a source into the conversation with the patient, but you don't impose that on the patient as the treatment plan. That's not the treatment plan. It is an idea of the way we might be able to treat this. One of the things that I always did with patients, and I think they appreciated it, was I would say, okay, we're going to list about 3 or 4 different options that we could take in your case. And I'm going to tell you what the pros and cons and what the evidence is for each of them. And then we'll make a decision together that we'll share the decision. And it worked. Patients usually became very comfortable because they were able to make a decision based on options and based on the individualization of care. But as I said, it's not easy. Um, it isn't something that you learn in medical school. It takes years of practice to learn how to do it properly. But when it's done properly, it is the best. It is the best of care.
Thank you very much. And I also I want to draw you to another thread in your book, Failure to Treat, where you explain the toll that this current health system takes on practitioners themselves. And this is not just about, oh, practitioners are experiencing burnout, but also the moral distress that practitioners have to juggle within doing what they think is medicine versus all of these decision-making tools that are imposed on them. What does it mean for practitioners to repeatedly know the right thing to do, but are unable to do it. How does that, make them feel?
It really wears on the practitioners. They find it obviously highly frustrating. And it is the reason why in 2024, 2025, we almost doubled and you said this earlier, and you're absolutely right. We almost doubled the number of doctors who left the profession, not through retirement, but just left because they just couldn't do it anymore. Um, and we're not replacing them fast enough, which is why, we're talking about maybe 100,000 fewer primary care doctors than we'll need in 2035, for example.
Mm.
100,000 primary care doctors that we won't have. And the reason is because people don't want to go into primary care. This pressure point that you're talking about of not being able to do what you want to do, primary care doctors feel that more than anybody. I mean, think about having a 75-year-old woman with hypertension, diabetes, lipid problems, maybe has some moderate renal disease, kidney disease, come into your office and you have 10 minutes. You have 10 minutes to see this person and deal with all of those issues in a primary care practice. Um, it's it's impossible. It's impossible to do it. It's bad for me as I'm a super specialized consultant and I have a hard time doing it. Think about trying to deal with five different organ systems in a 10-minute appointment. It's really very difficult, and it has led to a lot of frustration. And some of it is burnout, but as you said, I agree with you. A lot of people hang in there and they try to practice medicine the way they should, but ultimately they begin to do things that are probably not to the same standard that they would have liked to do them. So they start getting a little bit sloppy with things. And then when that happens, patient care suffers for sure.
Yeah, that is true. I wanted to pivot to ask you about patients, but you already said it's like every health care decision get to be borne by the patients, whether clinicians are able to do what they're supposed to do, or the system is not allowing them. The patients, in some ways, are the ones who the outcomes show up in either they are unable to receive dignified care or it affects the trust that they have within the system. And I would say this, someone told me and say, the thing with medicine is that medicine is in parallel and human existence is parallel. When human beings are able to receive adequate, dignified, quality care, they appreciate that, right? But what happens when those things break down is human figure an alternative way to deal with their issues, and those alternative ways are what create public health systems problem.
Hmm.
And that thing has kept me thinking for a while as someone who work at the intersection of policy and public health system. Like most of the outbreaks we see, most of the diseases we see come around is sometimes, things that people refuse to go to get care for, and then they begin to move within a community and became contagious, and that's how it spread. But the health system, in some way, are to blame because if we trust the health system enough to take care of our issues, why wouldn't that person go seek care? So, while we grapple on what this means in our communities, let's take another quick break. Do you want to help drive rural health forward? We are looking for passionate volunteers to support our work, from research to storytelling to outreach. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up. Welcome back. So, Dr. Kowey, I want to pivot now to actually discuss your book, Failure to Treat. And you made a strong case that health system itself is putting both patients and clinicians at risk. Why did you feel you needed to write this book and now?
Um, I I come from training program that was um, started by a Nobel laureate, Dr. Bernard Lamb. The book is actually dedicated to Dr. Lamb.
Mm.
And at the end, he was a Nobel Peace Prize laureate, actually, and in addition to being a world famous cardiologist. But towards the end of his life, he and I had several conversations. I visited him in Boston frequently, and he began to have his own health issues, and he was very, very distressed by the quality of the care he was receiving at the end of his life. And we had several frank conversations about it. And I came away from that feeling like it was time for somebody to speak up and to get the word out to as many people as possible. I chose, as you said, Shanas, I chose storytelling. So there are 20 different stories in the book because people, especially lay people, can understand it, can understand stories better. Stories actually are narrative medicine has a long history. We frequently present cases and stories as we begin grand rounds, for example, as a way of launching a discussion about a particular disease state. It's very widely used. So I decided to use stories, and I decided to hit on as many of the most important points as I possibly could. The central issue, and you've said this several times, and I think it really deserves just tremendous emphasis, is the central feature of these stories is that if patients had had a trusted physician, a primary care doctor, or somebody that they could talk to, that the vast majority of the problems that developed in this book wouldn't have happened. Trust is really a very important issue. You know, well, I was thinking as you were talking a few minutes ago about vaccines. I think vaccines is a perfect example of how the public has lost trust in the medical community, and therefore are taking paths with regard to their immunizations that are really it's almost insane. How could you argue about COVID vaccine, a vaccine that probably saved millions of people's lives and stopped the pandemic? And yet there are people who are still convinced that they don't really need that, or they don't need a flu vaccine, or they don't need a measles vaccine because they don't trust the medical establishment that's telling them that they do need those vaccines. Um, we really need to reinstate the trust to get back that trust of patients with of their physicians and their caregivers so that we can make meaningful progress in terms of patient quality of care.
Thank you. I wanted to follow up to ask you, in naming all of these failures that you chronicled in your book, and you mentioned there are about 20 of them, have you faced any resistance, either internally or externally, from those who have seen this book to say, we don't think this story resonates, or we don't think this is applicable within the practice, or, I think you are oversaying these things because
Right.
you just want to write a book. Have you experienced that since you launched?
It's a great question. I have to tell you that I had a lot of sleepless nights before the book was published, anticipating the possibility that people were going to come at me. It's been just the opposite. Anybody who reads the book, the first thing they want to tell me is, let me tell you about my story,
Story.
or somebody in my family, or somebody I know, something that happened to them. I have had a tremendous reception among physician colleagues who are really grateful that I did what I did because they think that for the same reason that I did it, they think that somebody's got to talk about it. Somebody's got to get it out there. The only minor one that I got was I had a physician assistant tell me that they didn't agree with my policy of having physician's assistants supervised. I mean, that was a relatively small point in the book, but a lot of them do function independently. That was a minor issue, but for the vast majority, it's been very widely accepted as being true, and not and again, one of the things that people tell me is, when are you going to write the next book and put another 20 stories together? Because we didn't hit all the issues that we could have. But the issues we hit, I think, were the most important, and it's resonated well.
Thank you very much for that. And I agree with you. Like when I was reading a couple of those vignettes, I was like, I should tell my story as well. And I think that is the best part that I like the book. And I think I told you this even before we started recording this episode. But I wanted to ask you, like when you were writing this book, who were you hoping to reach? Is it just clinicians, or were you hoping to reach the policymakers or decision makers, or just you wanted the general public to read it and digest it, the way they want?
All of the above. So one of the things that we're doing, my publisher and publicists are doing, is we're sending books to every single congressional person in Washington, all people in the House and all the people in the Senate and all the governors of the 50 states. Um, Beginning that process now with a cover letter explaining why we think that they need to take a look at this book. Um, so yeah, policymakers at the state level as well as at the federal level need to read the book and digest what's in it and understand, as apropos of your last question, this is not some maniac who's going off on a tangent and on a rant. This is mainstream thinking from physicians. This is what doctors think right now. This is the way doctors believe that medicine has gone, and we're all very frightened about what's going to happen if we don't fix things. I can't tell you how worried I am about this Medicaid thing. Cutting $1 trillion out of the Medicaid budget and not giving subsidies for the ACA, as we've heard repetitively. People are going to be underinsured. They're going to be not insured. We're going to have our emergency rooms crammed with people who are so very, very sick because they're not getting routine care. We're going to have common diseases. I was brushing up the other day on diphtheria. Do you think about that? I've never seen a case of diphtheria in my entire career, but we're going to see cases of diphtheria because people aren't going to be getting immunized. The consequences here are really astounding, and we don't have a long time window here. We have to do something relatively soon. So, yeah, it's everybody. Everybody's got to read the book, and everybody's got to think about ways that we might be able to make improvements.
Well, I am one of the everybody, and I've got the book here. And I was just wondering, like, I think if we start with the order of things, the health insurance business people need to read this book. And then the pharmaceutical companies who lobby, like they are the biggest lobbies when you go to DC. Like I go to DC every March to lobby for HIV funding. And I see a lot of pharmacists. They're always lobbying for one thing or the other. They need to read this book so that when they lobby and make decisions about the healthcare of people, ordinary people, they should understand the implications of what those policies that they write and pass on to customer care agents to tell us the
Mhm.
implication of what it does for ordinary citizens who are the workforce, by the way. So this is me saying, grab this book. It's in Amazon, and make sure that you read it like I have turned. You can see my own markings when I was reading it. That is how I read a book. If I don't mark, then I didn't read it. It was just so I'm just saying that it is actually everybody's concern because healthcare is everybody's concern. And I wanted to pivot to ask you again, Dr. Kowey. In your book, you um, talk about health system failures that go beyond isolated problems. So this is not one case or the other. What are the most dangerous failures you think we continue to underestimate in healthcare delivery?
Oh, it's the uh, corporatization of medicine, corporatization, bringing in private equity, these very, very large healthcare systems now that are buying up small hospitals and practices. conglomerates. They're going to be, and they can impose their will on medical insurance companies. They also will impose their will on practitioners and, of course, on patients. We have to regulate them. We cannot let them come in and do what they did in Philadelphia, buy up a healthcare system of three hospitals and close them within a year, and then sell off the real estate and make millions and billions of dollars. We can't let that continue. We can't let these large healthcare systems buy up physician practices and then begin to dictate the way the physicians are supposed to practice. One of my closest friends from college was an independent primary care doctor, very successful and very, very good. Patients loved him to death. Um, his practice was bought by a healthcare system, and within a year, they came in and told him that he had a quota of the number of patients that he needed to see in a day. And he basically said, "No, I'm not doing that." And they said, "If you don't begin to see patients on Saturdays to make up for the numbers that you're not getting, then we're going to start cutting your salary." And he ended up retiring probably earlier than he needed to because he loved what he did and he was still very vital. But that's what happens when they can dictate terms. There's only one alternative. The only alternative is to leave, and that's what's happening, unfortunately, in our healthcare system. So, yeah, I think the biggest challenge right now is this corporations taking over what's happening in the medical landscape.
Thank you for that response. And I want to quickly just go back to policy because, like, I think it begins with strengthening our policy landscape. And then when we do that, it trickles down to informing the micro decisions that all of these people we keep mentioning take because they hinge on the broader policy um, that is made or that is put forward within the government space. And I think that is the most important thing to start with. So, and you make this case in your book that, in trying to fix healthcare without changing the financing behavior is I think that is where we get it wrong. Because until we change the health financing behavior of those who make these financial decisions, from a policy perspective, we'll continue to consistently see failure within the system. So I want to ask you a couple of questions altogether. What incentives do you think that would actually ultimately produce good care? So what would be, let me rephrase back. I think I'm putting a lot in my mouth. What are those incentives that you think would change the behaviors of the policymakers towards seeing ways to make good policies that would drive a more strengthening of the systems?
We have to begin to reward um, physicians for um, taking care of patients and stop rewarding hospitals and physicians for doing procedures and operations. So, primary care doctor salaries are about a half of the salary of a consulting cardiologist who does cardiac catheterizations. We have to change that paradigm. We need to reward people for taking care of patients, give them enough time to do it, and then reward them financially. One of the things that really makes me laugh sometimes is that, there are lots of other countries in the world who get it right, right? The Scandinavian countries, for example,
Yeah.
have a wonderful system of healthcare, and they don't they reimburse their physicians not on the basis simply of procedures, but also they do provide some incentive, but the base salary structure is so much better than what it is here. Um, we need to pivot and make physician compensation much more compatible with what we have in other countries, and the models are there. Patients get good care. There's no reason why we can't do that. So I think some of it has to do with rewarding physicians differently, and another has to do with trying to take the money that's in the system and use it properly. And we're spending $5 trillion a year on medical care in the United States. There's no reason why we can't do better in terms of apportioning it to improve the quality of the patient's care that we're giving.
Mm. Thank you. And when these things are not done, who should we hold accountable? Because we can be anybody and we can be nobody. Who should we hold accountable for this systemic conversations that we are having right now?
Well, you mentioned lobbyists. I think there are again large corporations that lobby for things. I mean, there's so many device companies and companies that make things and drugs
Mhm.
that are very expensive that are being rewarded with very large profits. We can start there. We can start regulating those as better. We can do a better job of bringing down the costs of things like commonly used drugs. We're hoping to make some progress there. But we need to do better. We simply have to change the way we reward doctors and practitioners and control a little bit better about what happens in industry.
Thank you. And if policymakers are really paying attention to this book, like you said, you've sent a couple of them to Capitol Hill, what would this book ask of them?
It would ask them to dialogue better with people in the medical profession. One of the other areas that I think is wanting is that we have our professional organizations haven't done the best job of advocating for the change that we need either. We need better conversations with our between our professional organizations, our representatives, and people who are in power in order for them to hear the things that we need from them. These are not, I mean, there are physicians in Congress. There are not very many of them. These are people who don't really understand the issues. The book is an attempt, as you've said several times, to explain it. And that's where it has to start. They need a better understanding of what the problems are before they're ever going to be able to confront them.
Thank you for that response. I'm still within this policy space, and I'm going to ask you. One thing that I noticed throughout the book is that you tend to be very careful around discussing politics. And even though you and I know that politics is central, like the lobbies, they are playing politics, with health financing and being able to have use lobbying as a strategy to get upper decision making hands within the policy spectrum to make decisions. And in many ways, you circled around before you named it. But one thing that I found powerful in your statement, and I'll paraphrase this, is that you said while you criticize many of the policies put in place by the federal government, neither political parties have done much to remedy the current situation. You went on to argue that, we are left with a gaping wound, one that is a band aid, one that a band aid would not fix easily. You also note that most of the changes we need are unlikely to happen at the federal level. And I agree with you. But rather, we should focus on state level, which means put pressure on local legislatures, become the more, putting pressure on local legislatures becomes the most productive strategy. So I want us to sit with this a little bit more and discuss two things. First, I, I think that I know what I want to hear, but I want to hear your perspective. What role do you think local legislatures needs to begin to play in strengthening health system, especially for underserved rural communities who are actually their voters, who they go to campaign with? Like when I see them have or hold these town hall meetings in local environments, I am like, this is the time where you talk to your constituents, but do you also come back to discuss their challenges? So what role do you think they should begin to play in strengthening health system?
Well, it's very difficult for them because there's only so much they can do with the limited resources that they have. I know obviously the federal government has a lot more resources that they can bring to bear. However, this conversations with hospital administrators, people who lead hospitals in their area, can uncover a number of issues that might be able to be addressed to facilitate keeping these hospitals viable. I mean, we just had, for example, Hahnemann University close in Philadelphia. I don't think that there was a very large amount of discussion that went on between the Hahnemann administrators and the local government as to what the implications of that was going to be and what the local government might be able to do to facilitate keeping Hahnemann open. And when it closed, it created a tremendous healthcare desert in the middle of Philadelphia. That's a gaping area that we're never going to be able to fill. Um, I honestly don't know exactly what these people might be able to do because, as you've said several times, it comes down to funding, it comes down to financing. How much they can contribute to this situation is really something that I really don't have a lot of knowledge about.
Okay, thank you for your response, and that I appreciate the sincerity of how you perspect it. But I also want to shift this to the upper level and ask, what responsibility do you then think that the health system influencers, the lobbyists and the insurance companies and government, now this is at the federal level, what do you think that they could do better to support the healthcare system?
Um, well, there's so many things that they could do. Obviously the most important thing is that we need. I'm not necessarily going to echo things that Bernie Sanders has said, but I think we need to get to a place where everybody has access to medical care. At a very basic level, everybody should be able to access emergency care and primary care. Um, if people want to buy higher levels of insurance, then that's fine. But basic health care is not something that people should be deprived of. It's like education. It's like food. It's a basic staple that people should have access to. So I really believe at a federal level that the ultimate answer to this is to finally get over the hump and say, we're going to devise something that makes sure that everybody has basic health care, young and old, poor and rich. And until we do that, as every other developed country has done, I don't see how we're ever going to be able to take care of our people the way we need to.
Thank you so much, Dr. Kowey. As we now wrap up this conversation, I want to see if I can be able to reflect all that we have discussed and what I read from the book. I want to start by saying that you argue in the book that many of the failures we see in the healthcare system are not just because people do not care. And that has showed up a lot in our conversation to say physicians do care, but the system is in some ways limit them. And when I define system in my academic environment, I call them everybody. And that is why we included the place of patients in this decision-making spectrum. So, one other thing that really stand out for me in failure to treat is how when you describe your own experience as a patient, you speak so highly of the care providers and the ancillary staffs that, who show up every day and work hard. So it means that we definitely do have beautiful people. And I would say my primary care provider, I don't want to mention, I'm almost nearing mentioning his name here, but I don't want to mention that. But I trust him so much that even when he sends me, he refers me to a consultant. I am only speaking to that consultant to the level where the consultant want to work with my care provider because
Mhm.
that's who I would default to regularly. So I appreciate the fact that you speak so highly of these care providers because despite the constraints of the hospital settings that they do work in, however, they come through every day still holding on the hope that their work can make a world a better place. So I think when we bring that down to rural health, and you talk so beautiful about the implication of all of these things in rural health settings, it's far more pronounced. Caregivers are working under immense and limited pressure and limited resources, yet they continue to show up. For many of them who are still working within the rural environment, they continue to show up for their patients and their communities every day. I would say that their commitment is what is still holding rural health together. And with all of these financial constraints, and decision-making tight environments, I want to appreciate them especially for continuing to work in these spaces. Even though I would like to close on this note, but Dr. Kowey, I will not leave you without a final word. And I like to always close on a good note where I ask my guests what they are hopeful for. So to you, what do you hope that the readers or listeners of this podcast take away? If they don't walk out with anything, what is that one thing that you want them to take away from this episode or from reading the book Failure to Treat?
I just want to comment before I do that about what you said about healthcare providers in this country. They're heroes. They are heroes, and COVID proved that they're heroes. What they went through and how they treated patients and got through a disaster, always with good spirit, always with energy, always with positivity, was just amazing. And then they are amazing individuals. I hope that the book makes their jobs easier, makes them appreciated. I mean, how could we not appreciate a nurse who takes care of a patient and does it in a loving, giving way? I mean, these people are treasures. We can't keep losing them. We can't keep bruising them. We need to nurture them. We need to keep them doing what they're doing for as long as they possibly can. That's what the book, I hope, does. If it does, then I've accomplished a purpose.
Thank you so much. Thank you so much for that response. And I agree absolutely with you. Thank you also for your willingness to name how the system works, and most importantly, for how you describe these care providers. Like, you use the right term, calling them heroes. They are heroes. And the way you also reflected between being a physician, a patient, and an author, like, those things move smoothly in the book, and it show up in the way that you have passionately described and have this conversation with me. So I really appreciate you taking time to join me and for contributing so thoughtfully. To everyone listening, thank you for joining us on today's episodes of What About Rural Health? I want to say before I close out, please go to Amazon and grab the book Failure to Treat. It is one book that I want you to read as we continue to advocate for improved healthcare system. That is one book you want to have in your shelf. If this episode moved you, challenged you, or made you think a little bit differently, please follow us, subscribe, but most importantly, leave us a review on your favorite podcast platform. As always, let's keep asking the question, what about rural health? Until next time, I'm still your host, Chinasa Imo. Bye for now.